Most of healthcare governance is based on implicit assumptions and unspoken expectations that go all the way back to the founding of the nation's first hospital by Ben Franklin in 1751. And they served us very well for 100 years, 150 years, but it's over 250 years old now, and it's straining under its age and also under all of the pressures that are occurring in the environment. So some of the implicit assumptions of governance were, first of all, uncompensated trustees, voluntary trustees, minimal to manageable time commitments, lack of accountability, diffuse authority, lack of term limits for board leaders and frequently for board members. The rapidly changing and radically challenging healthcare environment is making governance much more difficult. But then secondly, and probably more impactfully, are the changes that we're seeing in society. A 24-hour-a-day, 7-day-a-week business environment, time is at a premium, and as the time pressure on society grows, the time demands under the current model of governance are also growing. So governance is taking more and more and more time. And so we may very well be reaching the limits of the current model of governance, where you can't get people to volunteer their time to serve on a bunch of different boards. So all of this puts together, really paints a very worrisome picture for the future of the traditional model of governance. There was one other aspect of this model which is important to mention, and that is that there was this belief that governance on behalf of a community required governance exclusively by members of that community. So if you're a hospital that serves a city, only people who live in that city would be on the hospital board. The problem is that what used to make that work is all the social and economic and political connections. And now what's inhibiting it from working are the social, economic, and political connections. So that if a board needs to make very difficult decisions, which boards need to do, which people in the community won't understand or won't like, it's the fact that they're of the community which makes it very difficult, if not impossible, for them to make those decisions. Within the context of community-based governance is, you get people who are willing to volunteer their time but don't have the expertise and skill sets that a complex healthcare organization requires to effectively govern it. So increasingly what we're seeing are, in the available pool of board members, only a very small subset of them really have the characteristics, competencies, skill sets, or expertise which are required to effectively govern the board. We may need to compensate board members. We may need to move toward a professional model of governance where you have people who are certified in healthcare governance, and then they may earn a substantial portion or all of their living by serving on boards in non-competitive regions with each other. There needs to be some type of a quid pro quo where an organization can say, here's how much time it's going to take for you to help govern this organization. And if you make the commitment, you must fulfill the commitment. And we'll try to streamline the governance model so that it doesn't waste your time. But this is how much time it's going to take. And we'll pay you, but you have to put in the time, and you have to do the reading, and you have to be a thoughtful participant. We use the same model to govern what Peter Drucker called as the single most complex business model in human history, the American hospital, that we use to govern our local YMCAs or Girl Scouts or United Ways. And the same model is not equally applicable. First thing is, are they truly embracing, recognized, well-known best governance practices under the old model? So if they're doing continuing education, if they're doing competency-based selection, if they're doing individual board member performance evaluation, if they have clear distinctions in role and responsibility between the board and management, and between the board and its committees. For those boards who are doing it and the trustees are complaining about the time, or there are board members who are missing meetings frequently, or it's difficult to maintain quorum at meetings, or people won't participate in continuing education, all of those are indicators and warning signs that they need to think about a new model of governance. Difficulty in recruiting board members. One of the other things we're seeing, and this is a very big warning sign, is that boards are aging faster than the general population. The number of boards that have members age 50 or younger has declined precipitously over the last decade. So another litmus test would be, can you recruit members of millennials and Gen X to the board? And once you recruit them, can you retain them? So if you cannot get people younger than age 50 to join your board, or if you get them to join the board and then they're shocked at how much time and energy and effort it takes and they stop coming to board meetings, that tells you that the model isn't working. Evolving to a new model is challenging. You're going to have to disrupt the old model and then create a new model. And so if there is any incremental step, it would be making sure that you elevate to best governance practices across the board in the current model of governance. And if you do that, then what you may do is buy some time to keep that old model working for a little while you're thinking about what the next model would be that's appropriate for your organizations. Do you want to professionalize governance? Do you want to downsize the board? Do you want to pay board members? Do you want to let's use a very extreme example, convert the organization from a not-for-profit tax-exempt organization to being a not-for-profit non-tax-exempt organization, which would immediately free you up from the IRS governance requirements. So there are a variety of paths to it, but when you hit a certain point, you have to flip a switch.